Okay, so got some questions. Today's session. I mentioned in recent sessions that I have two ways of determining if the upper arch is wide enough, the intramolar width, and if we have enough room for the incisors. What about looking at the room for canines and premolars to determine if you're done expanding? So transverse expansion is designed to widen the arches and is there to determine if you've got enough room for the front teeth to fit. From an orthodontic perspective, that's what width provides, room for front teeth. From an orthopedic perspective, of course, tongue space is also part of that equation. But we know what the normal kind of average for intermolar width of 6 to 6 at the cervical margin is in order to provide room for the orthodontic positioning of the majority of teeth. And studies by Banker, studies by McNamara show intermolar width on average being about 37, 38 millimeters for reasonable orthodontic alignment occlusion. We know that this is, of course, just an average, a mean or an average. That some people need more width than that 37.5 mil, some people need less. How do we know? Some people have bigger teeth, some people have smaller teeth. So we use intermolar width as a gauge so that when we hit that 36, 37 millimeter range, we have to take stock of whether we're going to continue to expand or whether we've got enough. How do we know if we've got enough? Well, if the front adult teeth don't fit, and you've still got a curve of Wilson to flatten out in the lower arch, then you're probably going to need more than 37.5 mils. If you have very small teeth, and sometimes 35, 36 is enough. You have enormous teeth, 40 sometimes is not enough. So we know intermolar width kind of norms, and then we have to customize to the individual based on the size of the incisors fitting between the canines. Canines and premolars sit on the sides of the mouth. Premolars are effectively side or back teeth. Canines sit on the intersection between being front teeth and side teeth. Width is important for front teeth. Depth is important for side and back teeth. Whether your side and back teeth fit has little to do with the width and much more to do with the sagittal depth. Sagittal depth in the side and posterior region isn't really gained by transverse expansion. So making decisions about whether we stop transverse expansion based on whether your premolars and canines fit doesn't make a whole lot of sense, because you can't widen your way out of an AP problem. All right, next question. For a child with posterior crossbite, can you have them do GoPex with the plates in place because there's an occlusal table to allow the mandible to center itself in the midline? Or do you wait until the crossbite is corrected to start the GoPex exercises? If you have a significant crossbite, you're going to have a crossbite flange in most cases. When you have a crossbite flange, I tend not to start GoPex until the crossbite is corrected and the flange is removed. It's just not particularly comfortable to chew hard and fast with the crossbite flange. When we have a crossbite, often we shift functionally to accommodate the crossbite. Functional shift moves the joints out of a balanced relationship. And again, avoiding loading a joint kind of asymmetrically or out of its normal ideal range is not recommended. When you have an anterior crossbite, if it's a mild crossbite, then you will still have a small amount of functional shift potential. So we don't want to load the joint out of its normal range. If you have a very deep anterior crossbite, we will often have to have a bite raising grab. If that's enough to clear the crossbite, then you can start GoPex in the initial period. But we tend to find when you jack open the bite to correct the anterior crossbite, you lose a lot of the leverage for chewing because you can't close to the normal chew distance. So again, I tend to not focus on the exercises when we have crossbite. Only after we've eliminated the crossfire with the expansion and the cat wire activations, then we remove the crossbite flange or remove the bite raising ramps. And then we can close back to a reasonable kind of distance for which approaches maximum intercuspation range. So we reduce the freeway space between the occlusal surfaces of the teeth to kind of a normal range. Then we start the exercises. So I've found in my experience, it's not practical, it's not ideal, it's not necessary to start the exercises until you've corrected the crossbite for those reasons. So that's why I set that rule. And if you consider the rationale behind it, hopefully you will find that it makes sense for me to set that particular rule. Question. For a child who breaks the lower clasps arms, but the arms are consistently maintained 45 degrees each time he comes in, and he has correct insert removal technique, can this clasp breakage still be from biting it in place? I have a kid who broke his right side clasp on previous appliances, but the clasp would always be squished when he came in. Now he's calmed down and inserts and removes much slower, and the arms are no longer coming into squashed. But now he broke right side arm at the acrylic at the connected point after 40 days of use. What are your thoughts on the etiology of this break? So the arms can break so the clasps can break in commonly two zones. One at the solder, and it's the arm that breaks, and one at the acrylic interface, which is the connector. So one is a connector breakage and one is an arm breakage. Arm breakages are mostly from flicking the plate and biting at home and basically squashing the arms flat against the connectors. Connector breakages, so that's breakage at the acrylic, is just from a heavy bite. So just normal wear and tear in children who brucks, children who have a strong muscle tone, they can just wear out the metalwork. What accelerates this? Maybe from the laboratory damaging the wire when they polish it. Because they polish the acrylic, and if they're not careful, they can damage the wire at the interface. Another laboratory-based fault will be if they overheat the laser weld and kind of burn through the metal. What's a common patient issue? Flicking the plate with the tongue and crunching at home. Bruxing and clenching. What's an operator issue? just being kind of aggressive or forceful with adjusting the appliance. So they're the common um, causes of wire breakage. In this case, it just sounds like he's got high muscle tone and maybe bruxes a little bit on the plate. And it's quite possible, if it's only been a month and a half, that the wire might have been a little bit damaged in the polishing. So how do we know? How do we figure it out? We have to be mindful and observe the appliance, inspect the appliance before we insert it. And then if we note wire nicks and over polishing issues, then obviously we can record that and bring that up to the lab as a potential point of failure in the future. If we observe the bite ramp has heavy indentations from the acrylic being worn by the opposing dentition, you'll see that in children who brux or have heavy muscle tone, then you'll know that it's most likely a breakage on child just being very strong in their bite force. So you can, if they're strong and they're brux, you just have to eat it yourself. If they flick it and bite it home with their tongue, then they have to wear the cost. If you've noted there's damage in the appliance before you insert it, then the lab wears the cost, right? So that's how you figure it out. All right, next question. Will you please help me understand in which cases utilizing springs in the plate is recommended? Comes from a question for a patient with open bite skeletal. I recommend putting the springs nearly vertical drawn with your red lines. So intrusion springs are normally prescribed in upper stage 1 appliances when we are planning a DE extraction. So skeletal open bite cases in the mixed dentition can be managed by changing the permanent dentition occlusal plane. So an open bite skeletal pattern will often have contacts in the molars, but an anterior open bite. So you'll have the incisors in a separate occlusal plane to the molars and the canines. So that's common in a skeletal open bite. In a mixed dentition, where the ears are still stable, you have an opportunity, if you plan it well and time it well, to create a mechanics called auto-rotation closure. It's borrowed from a surgical technique where you are trying to close an open bite by intruding the posterior teeth so that your rotation of the jaw can be sufficient to close the anterior open bite. So in the current orthodontic era, in older patients, this is done using temporary anchorage devices, TADs, on either side of the molars, and then using elastics, connecting buccal screws and palatal screws to intrude the posterior teeth. And that allows the bite to close down, because if you reduce the vertical dimension of the posterior teeth, then the incisors, which are in an open bite relationship, can meet if the mandible can be rotated more than the current occlusal relationship. In postural orthodontics, if we have a patient who still has solid E's, so prior to the age of 11, that's most likely, then you can intrude the 6-year-old molars using intrusion springs. We clasp the E's because they tend not to erupt. They tend to be fairly stable anchorage points. And we have an intrusion spring on the 6-year-old molars that can be activated to intrude the 6s. The springs can actually intrude the 6-year-old molars a significant degree, often almost to the point where you can submerge the crown. If you do that, you will effectively bring the 6-year-old molars, which have an occlusal plane currently in line with the E's and the D's and the C's, to a new occlusal plane that lines up with the permanent incisors, which are in an open bite relationship. When you've activated those springs, you end up with two occlusal planes. The current occlusal plane, which are the E's, the D's, and the C's, and then a new occlusal plane that corresponds with the 6-year-old molars that you've just intruded and the central incisors. Once you have those springs expressed and you have intruded the 6s, when the timing is right, at the exfoliation of the first primary molars, the D's, you will effectively have only the E's holding the bite up. And you'll have the first permanent premolar starting to erupt, but at approximately the same occlusal plane as the 6-year-old molars and the permanent incisors. At that point, the patient will have the remaining primary molars extracted simultaneously, and that will effectively change the occlusal plane from the previous occlusal plane, which has an increased vertical dimension, which is common in skeletal open bite cases, to the occlusal plane that's set up at the incisor level. And with all the old teeth cleared, the mandible can over-rotate and close to meet the 6 molars and the incisors simultaneously. Occasionally, you have to grind down the C's to allow the bite to close completely, but usually the C's can be left without being removed or a small amount of equilibration. So skeletal open bite cases where you are going to do what we call a DE extraction is when we would use intrusion springs. Um, See if I can find a case to um, illustrate this. The skeletal open bite, which we auto-rotate closed. Okay, so you'll see here the 6 molars are in contact on the right. You'll see here 6 molar on the top has been intruded to create like a 5 mil gap. And you'll see the old occlusal plane where the E and the D are still in contact. We've also intruded the upper incisors because we're being aggressive. This is an orthotrophic case, but same principle. So we intrude the sixes, we intrude the incisors. Normally with the big open bite, you don't have to intrude the incisors. Then you're left with two occlusal planes, the 6 molar and the incisors in one occlusal plane, and the primary molars in a second occlusal plane. When the D's start to exfoliate, we extract the E's and the D's on the top simultaneously on both sides, and that allows the bite to now take on the second occlusal plane, and the big anterior open bite closes down. Now, bite closed, then and let molars are up back into place if you wish, if you've overdone it. good planning, management, everything starts to fall into place. You've established a new occlusal plane, one that was divergent to begin with, one that you're allowed to close into a more horizontal fashion. Okay. And I think that's it. Okay, so that's intrusion springs for DE extraction cases in divergent growth patterns. Okay, if there's no further questions, I'll have my lunch. No more? Okay, call that a day. Thanks, guys.